Privileged to be introducing one of the perhaps great practitioners the Philippines ever had. His physical assessments include a wide range of patient ages. He has worked with patients with musculoskeletal disorders, acute or chronic pain, and spine dysfunction. So basically, we basically need to hear from this doctor. He leads a consultancy services in massage therapy industry in the Philippines, units accredited by the Philippine Department of Health. Ladies and gentlemen, I think without further ado, let's deserve a warm Bagyong Tisoy welcome for Dr. Jeff Cover.
Good afternoon, everyone. I'm Dr. Cover. Today, that topic will be focused not on the TMJ, not on the craniomandibular in particular for pathology, but more on how to integrate the jaws within the cranium and the cranium within the other body units. So that's the purpose today. Try to see how we can integrate that particular area, the jaws, into a more extensive system, which is the musculoskeletal system. The meaning with that today is to integrate these two systems, the oral fascial system, the stomatognatic system, and the musculoskeletal system. So what you could see here is a representation of the body, the somatopy, soma for the body, topy for map. And actually this is a map of the body into your brain. Of course, it's representation, a fictive representation, but at least you can see that that little person is not proportional. There is disproportion, is it? So you can see, for example, that the face, the oral facial system is well represented, either into the motor side or into the sensory side. What does that mean? That means that that part of our body is well connected with neurons in our brain. Our brain dedicates a lot of neurons to control every muscle, every sensation into that system. For us as osteopaths, we pay a lot of attention to anatomy. The whole work we can have with patients is based on anatomy and physiology. And then here you can see the hyoid bone in position, in anatomical position here, regarding the ramus of the mandible. So that bone, that little bone, is in the back position, actually, when you see here the mantle of the mandible, in the back position, and we will detail a little bit more how that bone is connected with the mandible up there and down there with the upper thoracic part. You can see that's the sphenoid here in the front, in the coronal section over there, and you see that bone is in the middle of the cranium. It's in between the frontal and the ethmoid bone in the front, and posteriorly with the occipital bone. So you can see the relationship with the frontal bone over there and the temporal bone here, and you can see also there the pterygoidian plates of the sphenoid bone. Why are we pay attention to the pterygoid plates? Because you have muscle, we have muscle there, the lateral pterygoid and the medial, and they are involved into the motion, of course, of the jaw. Why there is movement between bones in the cranium? What could you say about this? If I tell you there is kind of minimal movement on bones of the cranium, what could you say? Yes, thank you. There is suture. We can go back a little bit, please, just on the dry bone. Again. Yes, you see this suture over there. All this suture means bones are connected bone to bone with a fibrous connection. This is not a synovial joint like the TMJ, but these are fibrous joints. And we can see how effective these kind of joints are when the baby is delivering. So let's go to body unit junction. How the cranio-mandibular system is connected with the other system. That connective tissue here is the tectorial membrane. Connective tissue becomes a posterior longitudinal ligament through the vertebral canal. So there is connective tissue between the head and the spine, and that relationship based on this connective tissue can explain how, when you do work into the mouth, that work can also implement some change into the vertebral column. And here you see the complete joint with the capsule, the fibrocartilage in between the condyle and the condyle process, and the ligaments around to make that system very performant. So that joint, as you know, is a bit particular because there is a fibrocartilage dividing the space in two rooms, and the condyle process of the mandible can move back and forth regarding that organization here with that synovial joint. Moving to the muscles, let's start with the muscle in the back of the head, because when you do work in the jaw, how is your patient? The patient most of the time is lying in a chair, dental chair, with the head a little bit in extension, is it? So if the head is a little bit in extension, you put these muscles in rest, the suboccipital muscles. These short muscles at the back of the head are controlling the positioning of the head and the vision. So if there is any abnormal tonus here in this muscle, the head will need to compensate with the vision, with the vestibular system, and also with all the connection in between the cranial nerves and the muscles. We will see that a little bit later. So these muscles, these suboccipital muscles, are the one very important to connect the craniomandibular system to the cervical spine. The platysma, that muscle is moving up to the mandible, but is also coming from the shoulder and the pectoralis major. What does that mean? There is a muscle, a very thin layer, which is the cervical superficial layer, and that layer is connected with the jaw. So the shoulder and the pectoralis major are connected with the jaw. All these muscles are connected different systems, like the mandible, but also the hyoid bone over there, and also the masseter with the zygomatic bone over there. And there is connection, for example, with the stylohyoid muscle from the styloid process of the temporal bone. So the temporal bone here is connecting through this muscle, the stylohyoid muscle, regarding the connection with the hyoid bone and then with the mandible. So the tongue with a lot of muscle, of course. I guess you pay a lot of attention of the tongue because that tongue can be a problem for you if that tongue is not well positioned into the mouth. If the tongue is in a back position, you will be probably in trouble to make your work properly. And if the tongue is more in the front, between the teeth, like some kids, you will be also maybe in trouble. So we pay attention to all these muscles, and in particular the tongue, the position of the tongue into the mouth. Ligaments also play a part into stabilization for the jaw. And you can see how the sphenomandibular ligament is connecting the sphenoid bone we talked about previously that sphenoid bone, and the mandibular. And you can see also how the stylomandibular ligaments from the sphenoid process of the temporal bone is also connected here with the mandible. So, about the nerve, you know how it works already. We have a main connection of muscle for the jaw with the trigeminal nerve, the fifth cranial nerve. We have the facial nerve involved into the motion of the jaw, and we also have connection with the plexus, the cervical plexus. At the very beginning, C1, C2, C3. Blood supply is also one of the major things for you, I guess, when you do surgery, when you do implants, when you do all the things around the jaw, you need to pay attention to at least some major arteries, like the mandibular artery. And you will see here, or the maxillary artery here, how that maxillary artery is coming. When we do resection of that part, we see the travel, the pathway of that maxillary artery. We have connection with the autonomic nervous system, with the sympathetic ganglion. These ganglion make the connection between the sympathetic and the parasympathetic nervous system, which are the ones to do things unconsciously for the patient, and they are more like automatic pilot for the secretion, for blood releasing hormonal system and everything. How? So that one is the real connection between the oral fascial system and the posture. If you want to look for any connection, you have to go through the reticular formation. That reticular formation is inside the stem brain here, that part. And that location is, of course, included inside the brain, but it's more regarding that brainstem over there. And that particularly location is connected with cranial nerves, and in particular the fifth and the seventh. So there is connection from the sensory and the motor side between that reticular formation, which is in charge of the muscle tone, which is in charge of how to control the pain into the body, the fibers, the reticulospinal fibers coming from that reticular formation going down, descending, are controlling pain sensation into your body. And regarding head and neck, that particular location is connected with cranial nerve, like the fifth and the seventh, but also the 10th, the vagus nerve, and the spinal nerve, which is in charge with the trapezius muscle, for example. We have that course training 1 year ago, and we did almost 6 days of training. That kind of training is open to DMDs because, again, with simple things, simple techniques, you can upgrade, or you can at least make your result more sustainable with your patient. We do connection each time between the craniomandibular system, the craniocervical system, and the spine, and the relationship with the foundation of the body, which is the pelvis. We have assessment for the posture. We are able to do basic analysis of how your work can implement new conditions for the muscles. Because each time you do work in mouth, you give information away from the mouth also into the neck, and the neck is connecting with the thoracic, and thoracic with the lumbar spine, and the lumbar spine with the pelvic. So everything is connected in terms of fascia, in terms of a relationship with joints, in terms of neuro control with the reticular formation or the somatopy you have into your brain. So each time we try to see basic hands-on treatment with cranial osteopathy here. This is the CST, cranial sacral therapy, based on the works of in the US. And we also, of course, make the connection with the rest of the body. One, at least even if they don't do themselves these hands-on treatment, they can have support from somebody else doing that job for them. And they work like a team with additional people into the clinic. And that's what I do with some of dentists. They refer me some patients because for any reason, we try to combine analysis together. We try to analyze how we can implement a treatment plan, and then we follow that treatment plan for the benefit of the patient, of course. Which muscle? A small muscle connecting the scapula in the back to the hyoid bone in the front. No, not the platysma. Platysma is connecting the chin with the pectoralis major. Trapezius, no. A small one. You're not so far. Okay, you're gonna go everything into anatomy nowhere.
Wait lang ah.
This is the omohyoid muscle. So, soft tissue technique is part of my treatment, is part of my training. Doing some tuina, amo, kind of Chinese approach also. Elot, for you here in the Philippines. Elot also do this kind of work, yes, I know. Yeah. I pay attention to the way you are working on the patient also, because you don't have any more tools into your hand. You're working with your hand, so which is totally different. You used to work with one tool in your hand, but here you used to work with your hand. So it's a different approach. That's it. Thank you for your listening.
One more.
One more.
Okay.
Alright, so let's do the cutting, then we do the countdown in 3, 2, and 1. Alright, there you go, round of applause, ladies and gentlemen. And then let's comply to the requirements of the and art. Ayan, and then sa ating chat room, may isip